Welcome to the deep dive. Today, we're really focusing in on hospital-acquired pneumonia, HAP.
That's right.
We've gone through the notes, pulled out the key stuff you need to get a really solid grip on it for revision.
Yep. Think of it as your essential guide. We'll cover the definition, causes, risks, how it develops, what else it could be, all the way through to management and complications.
And hopefully make it stick, make revision a bit less, daunting.
Exactly. Efficient and clear.
Okay, let's dive right in then. The definition.
Huh?
What exactly is hospital-acquired pneumonia?
So HAP. By definition, it's pneumonia that crops up 48 hours or more after a patient's been admitted to hospital.
48 hours. Got it.
Yeah. And while you might immediately think of, say, the really severely ill or immunocompromised patients, maybe those on ventilators, it's actually most commonly found in non-ventilated patients, which is interesting.
Huh. But the risk is higher for ventilated ones.
Oh, absolutely. Highest risk group, definitely. But just in terms of sheer numbers, more non-ventilated patients get it.
And the types of microorganisms involved, they can change, can't they? Depending on when it develops.
Precisely. So if pneumonia appears quite soon after admission, maybe it's still caused by bugs you'd see out in the community, like Streptococcus pneumonia.
Okay.
But later on in the hospital stay, that's when you're much more likely dealing with, well, tougher customers. Antibiotic-resistant ones.
Yeah. MRSA.
Like MRSA, methicillin-resistant Staph aureus, yeah. And things like Haemophilus influenza, Pseudomonas aeruginosa, other gram-negatives too. The hospital environment, it selects for these tougher bugs.
Right. So that leads us nicely into the etiology, the causes. What are the main culprits we're talking about?
Well, the most common bacteria we find are Staphylococcus aureus, including MRSA, of course, Klebsiella pneumonia, Pseudomonas aeruginosa, and E.coli.
Okay, the big gram-negatives in staph.
Exactly. But others pop up too. Streptococcus species, Enterobacter, Acinetobacter. Occasionally you might see fungal or viral causes, but that's usually in quite specific patient groups. Bacteria are the main story.
And it's not always just one bug, is it?
That's a really key point. Often, HAP is polymicrobial, multiple pathogens involved. And gram-negative enterobacteria and Staph aureus, again, including MRSA, are very frequently found together or alongside others. It shows how complex it can get.
Okay, so we know what it is, who causes it. Now, who's most at risk? Let's talk risk factors.
Right. This is crucial for prevention and early suspicion. There's actually a handy mnemonic that might help remember some key ones. A HIPP made.
HIPP made. Okay, I'm intrigued. Break that down for us.
Sure. So A is for advanced stage, older patients, weaker immune systems, often more underlying issues.
Makes sense.
H is for hospitalization itself, especially if it's prolonged, more time, more exposure.
Yeah.
I is for an impaired immune system.
Yeah.
Makes it harder to fight anything off.
More natural.
First P, invasive procedures. Think intubation, central lines. They create entry points.
Right. Breaching defenses.
Second P is for exposure to those pathogens we just talked about, the healthcare-associated ones. M is mechanical ventilation. Huge risk factor. It bypasses all those natural upper airway defenses.
Well, okay.
The second A stands for antibiotic resistance, or rather prior antibiotic use, which can select for resistant bugs.
Right, wiping out the competition.
Kinda, yeah. The second I is for impaired respiratory function, so underlying chronic lung diseases.
Like COP.
Like COPD, exactly. And the final D is just for other underlying chronic diseases more generally, which weaken the body.
A HIPP made? That's quite comprehensive. Thanks.
It covers a lot of the big ones.
So, building on those risks, how does the infection actually develop? The pathophysiology. Walk us through the steps.
Okay, so step one. The pathogen gets into the respiratory tract, usually inhaled or aspirated.
Right.
Now, in a patient with those risk factors, their normal defenses are often, well, compromised. Maybe they can't cough properly because they're intubated or their immune cells aren't working optimally.
No, the bugs aren't cleared.
Exactly. Step 2 is overcoming those impaired defenses. Step 3, compromised airway clearance lets them stick around. Step 4, they start to colonize, multiply, and establish an actual infection in the lower airways.
And then the body reacts.
Step 5, inflammation. The body sends inflammatory cells, releases cytokines. This causes tissue damage in the lungs. That's what you often see as opacity on an X-ray.
Leading to the symptoms.
Step 6, yes, the clinical symptoms appear: fever, cough, shortness of breath, etc. And step 7, unfortunately, if it's severe or treatment is delayed, it can progress. Sepsis, respiratory failure. Serious complication.
A real cascade effect.
Okay.
Now, a patient in a hospital develops these symptoms. How do we know it's HAP and not something else?
Right.
The differential diagnosis must be quite broad.
It really is. You have to think widely. Firstly, other pneumonias. Could it be community-acquired? Maybe they had it incubating on admission. Or aspiration pneumonia, if there was a known aspiration event.
Okay.
Then there's ARDS, acute respiratory distress syndrome. That's severe lung inflammation, but it can have non-infectious causes too. And speaking of non-infectious, pulmonary edema fluid on the lungs, especially relevant in cardiac patients.
Good point.
Then you've got a whole list of other lung possibilities. Pleural effusion, pneumothorax, pulmonary embolism, always a big one to consider. Or even exacerbations of underlying things like asthma, COPD, bronchiectasis, fibrosis, even malignancy or sarcoidosis.
Oh, okay. Lots to rule out.
And don't forget complications of pneumonia itself, like empyema in the pleural space or a lung abscess.
Okay, let's try that example question for the notes to anchor this. A patient develops a fever and cough 5 days after admission for a heart condition. Besides HAP, what other pulmonary issues might you consider?
Yeah, classic scenario. So 5 days in, heart condition. Pulmonary edema is definitely high on the list. You'd think about that carefully.
Okay.
Pulmonary embolism is also a strong possibility, especially if they've been less mobile post-admission.
Right.
And you'd still keep other infections in mind, maybe aspiration if relevant, or even just worsening of their baseline condition. But edema and PE would be top differentials alongside HAP there.
Okay, that helps clarify. Now, epidemiology. How common is HAP, particularly here in the UK?
Well, the exact numbers vary, depending on the hospital, the type of ward, the patient mix. But hospitals and long-term care facilities are the hotspots, naturally.
And it mainly hits certain groups.
Yes. It primarily affects older adults and people with those underlying health conditions we mentioned in the risk factors. It ties back directly to vulnerability.
Okay, so let's get practical. What are the signs and symptoms, the clinical features we should be looking out for?
We can split them into symptoms, what the patient tells you, and signs, what you find on examination.
Right. Symptoms first.
Symptoms often include fever, sometimes with rigors, those shaking chills, general malaise, feeling unwell, anorexia, so loss of appetite, dyspnea, shortness of breath. A cough is typical, often producing purulent sputum, thick, colored stuff.
Okay.
You might get hemoptysis, coughing up blood, though that's less common, and pleuritic chest pain, that sharp pain that gets worse when you breathe in.
And the signs, what would we find?
On examination, you might see pyrexia, the fever itself, cyanosis, maybe that bluish tinge if oxygen levels are low. Confusion is a big one, particularly in the elderly. Sometimes it's the main presenting sign.
Really? Just confusion?
Yeah, it can be. Also, look for tachypnea, fast breathing rate, tachycardia, fast heart rate, maybe hypotension, low blood pressure if it's progressing towards sepsis.
And listening to the chest.
Ah, yes. Signs of consolidation are key. That's where the lung tissue is filled with inflammatory stuff instead of air. So you might find diminished chest expansion on that side, a dull sound when you percuss or tap the chest.
Instead of resonant.
Exactly. Increased tactile fremitus, feeling more vibration when they speak. And listening with the stethoscope, you might hear bronchial breathing, harsher sounds than normal, maybe crackles, and sometimes a pleural rub if the surfaces are inflamed.
That's a detailed list. Any quick way to remember the key symptoms? You mentioned a memory aid earlier.
Yeah, it's not perfect, but you could try thinking feverish COPD as a rough guide for some common symptoms. Fever, effortless breathing difficulty, dyspnea, vomiting anorexia, expectoration, purulent, rigors, increased breathing rate, tachypnea, and sharp chest pain, pleuritic. The H is a bit redundant there, maybe hemoptysis, and COPD isn't a symptom but reminds you of the risk.
Feverish COPD. Okay, a bit rough, but maybe helpful as a prompt.
Yeah, just a starting point. Don't rely on it solely.
Understood. So we suspect HAP based on these features. How do we confirm it? What investigations do we order?
Okay, first-line investigations are crucial. Number 1, chest x-ray, PA, and lateral views. You're looking for new or worsening opacity. Always compare to previous x-rays if you can. That's vital.
Right. See what's changed.
Exactly. Second, white blood cell count with a differential, usually elevated in infection, but sometimes it can be low in severe sepsis or in certain patients.
Okay.
Third, pulse oximetry. Get those oxygen sats. Less than 92% is usually a marker of severity, needing oxygen. And fourth, a sputum sample. For microscopy, culture, and sensitivity, try to get a good quality sample, ideally non-invasively first.
Those are the initial steps. What if things aren't clear or the patient's really sick?
Then you might move on to additional tests. Arterial blood gases give you a much better picture of oxygenation, CO2 levels, and acid-base balance.
More detail than oximetry.
Much more. A CT scan of the chest can be very helpful if the X-ray is unclear, or if you suspect complications like an abscess or emphysema. It gives great detail.
Okay.
And remember, these patients are in hospital, so they'll likely have other standard blood tests done anyway. Full blood count, CRP, C-reactive protein to track inflammation, UNEs, urea and electrolytes for kidney function, LFTs, liver function tests, and blood cultures are really important to check if the infection has spread to the bloodstream.
Makes sense.
Depending on the situation, you might also consider pneumococcal and Legionella urinary antigen tests. And a follow-up chest x-ray is usually done, say, 6 weeks after recovery, just to make sure everything's cleared up.
Right, and if there's fluid around the lung?
If there's a significant pleural effusion, then aspirating that fluid for analysis, checking for infections, cells, protein levels can be really informative.
Okay, comprehensive workup. So let's say we've diagnosed HAP. How do we manage it? Treatment time.
Management really has two arms: prescribing the antibiotics and non-prescribing or supportive care.
Let's start with prescribing.
Okay, the absolute key here is prompt antibiotics. Don't delay. Because you won't know the exact bug immediately, you start with empirical therapy.
A best guess based on likely pathogens.
Exactly. Based on local hospital guidelines, common HAP bugs, and importantly, local resistance patterns. You also need to factor in the patient's own risk factors for having multi-drug resistant MDR organisms.
Like previous infections or antibiotic use.
Yes, or if they came from a nursing home, recent hospitalizations, things like that. Once you get the sputum culture results back, you then tailor the antibiotics, de-escalate if possible, or change if needed based on sensitivities.
Makes sense. And supportive care alongside.
Crucial. Oxygen therapy to keep SATs up. Sometimes non-invasive ventilation, or in severe cases, full respiratory support with intubation.
And what about non-prescribing interventions?
Well, as mentioned, intubation and invasive ventilation if they develop respiratory failure. Sometimes diagnostic procedures like a bronchoscopy, looking into the airways with a camera, or thoracentesis, draining pleural fluid, might be needed if they're not getting better or you suspect something else.
Okay.
But a massive part of non-prescribing management is actually prevention for the future. Influenza vaccination, really strict hand hygiene, general infection control measures in the hospital.
And antibiotic stewardship.
Absolutely. Using antibiotics wisely to prevent resistance developing further, that's critical.
The notes mention specific NICE antibiotic recommendations. Can we quickly cover those?
Sure. The NICE guidelines give quite clear pointers. For adults, 18 plus, with non-severe HAP, they often recommend coamoxiclav first line, assuming no allergies or contraindications. For severe HAP, or if there's a high risk of resistance, something broader like piperacillin with tazobactam, often called tazosane, is recommended.
And if you suspect MRSA,
Then you need to add specific MRSA cover vancomycin, teicoplanin, or linen solid.
right. What about children?
For children and young people, 18, NICE stress is getting specialist advice. But generally, for non-severe cases, in those over 1 month old, it might be coamoxiclav or maybe clarithromycin. For severe or high-resistance risk cases, options like piperacillin tazobactam, ceftazidime, or ceftriaxone might be used.
And MRSA cover again if needed.
Same deal. Add teicoplanin, vancomycin, or linezolid if MRSA is suspected.
Okay, that gives a good framework. So after treatment, what's the likely outcome, the prognosis?
It's really variable. It depends heavily on the patient's overall health before they got HAP, their baseline function and comorbidities.
Right.
Also depends on the specific bug causing it. How virulent is it? Is it resistant to antibiotics? And crucially, how quickly was the right treatment started?
So timeliness matters a lot.
Hugely. Unfortunately, HAP carries significant morbidity, meaning ongoing illness or complications, and mortality risk. It's a serious condition. Critically ill patients, or those with lots of other health problems, they tend to have a worse prognosis.
But early recognition and proper management can improve things.
Definitely. Getting on top of it quickly and appropriately makes a big difference, and prevention is always better than cure.
Which leads us to the final section.
Right.
Complications. What can go wrong with HAP?
Several serious things. Respiratory failure is a major one. The lungs just can't keep up with oxygen demands.
Okay.
Sepsis is another huge risk. That's when the infection overwhelms the body, leading to organ dysfunction. It can progress to multi-organ dysfunction syndrome. Very dangerous.
Right.
Locally in the lung, you can get a lung abscess, which is a collection of pus that can be hard to treat. And the background issue of antibiotic resistance complicates everything. It makes treatment much harder.
And these can be life-threatening.
Oh, absolutely. Severe HAP, especially with resistant bugs or in frail patients, can certainly be fatal. It really highlights why swift, effective treatment is so vital to try and head off these complications.
Okay. Wow. That was a really comprehensive run-through of hospital-acquired pneumonia. We've covered, well, everything from the definition right through to what can go wrong.
Yeah, hopefully breaking it down like that helps you, the learner, connect the dots for your revision. Seeing how the risk factors lead to the pathophysiology, which causes the features, guiding investigations and management, it all links together.
Definitely. And maybe a final thought for everyone listening to ponder. With antibiotic resistance becoming such a massive challenge, how do you think hospital protocols, infection control, antibiotic use might need to change in the coming years to better prevent and manage things like HAP?
That's the million-dollar question, isn't it? Constant vigilance and adaptation are key.
Food for thought. And for more revision help, do check out the resources online.
Yeah, head over to passthemsra.com and also freemsra.com for more great materials.
Brilliant. Thanks for joining us for this deep dive. We'll catch you on the next one.